when a woman is having her period, she is expected to experience some pain and cramping. So how do you determine what could be endometriosis versus normal period pain?
It's very challenging. I think when pain increases with time, that's something that people should be very much aware of. And if the pain actually puts you in bed, that is not normal. That is not normal period pain. And I think, having genetics as a principal risk factor, sometimes young people get not good advice from their mothers or their aunts who said, oh, this family is cursed with that pain. You have to take your Tylenol, right? And that's normal.
Hello, and welcome back to 20-Minute Health Talk. I'm your host, Sandra Lindsay. This March, we're dedicating time to understanding a chronic and often debilitating condition that affects millions of women worldwide, yet remains frequently misunderstood and underdiagnosed: endometriosis. As it's Endometriosis Awareness Month, we want to shed much needed light on this condition that can cause severe pain, impact fertility, and significantly diminish a person's quality of life. To help us shed light on this complex issue, we have a truly distinguished guest. Joining us today is Dr. Christine N. Metz, a highly respected researcher and advocate for women's health. Dr. Metz is a professor in the Institute of Molecular Medicine at the Feinstein Institutes for Medical Research at Northwell and the Donald and Barbara Zucker School of Medicine. Her profound commitment lies in advancing women's health through her research investigating critical conditions, including women's reproductive health, infertility, and notably endometriosis. Dr. Metz, it's truly a pleasure to have you here today. So let's start at the beginning. Could you please define endometriosis for our listeners? What exactly is it and how common is it?
So first of all, thank you for having me. I'm really delighted to be here with you. So what is endometriosis? We define it as the growth of uterine-like cells that are normally lining the inside of the uterus that grow outside of the uterus. And those cells look like what we call the endometrium, the uterine lining. They grow on the outside of the uterus, they grow on the ovaries, they can grow on the rectum, they can grow on the intestines and other organs within the peritoneal cavity or your abdominal cavity, and they can even grow on the lining of the cavity. And each month, they respond to hormones. So they can typically go through cycles of inflammation and bleeding. And when not treated, these things can result in some serious pain in many people, and infertility, which affects about 40% of people with endometriosis. It is a chronic problem. That means it's going to last for a very long time, and it is a common problem. It affects 1 in 10 teens, tweens, and adults with uteruses. And that's about 6 million American teens and women, if we just think about the United States.
Wow. So these cells are not intended to grow outside of the uterus.
Correct.
And that's the problem, because when a woman is menstruating, bleeding, you also have additional bleeding
at other sites.
At other sites.
Yep. We've even had patients in our study with nosebleeds that happened every single month, and they ended up being endometriosis lesions in their nasal cavity. It's very rare, but we've met people.
So what really causes this? Are certain populations more at risk for endometriosis than others?
So any person with a uterus is at risk. The biggest risk factor is one that we have absolutely no control over, and that's our genetics. So if your mother or sister has or had endo, you have a 5-fold increased risk of endometriosis. Very early onset of periods before the age of 11 is a risk factor for endometriosis.
But that's like most teens these days.
Yes, so onset of menstruation is a little bit earlier. Heavy bleeding and long duration of bleeding in the menstrual cycle, as well as short cycles, which means typically they're bleeding more than once a month, promotes the risk for endometriosis. So there's a clear link between menstruation and endometriosis. And in fact, there are very few animals that menstruate, only about 3% of all species, humans, non-human primates, a few bats, a little elephant shrew. And we have not observed endometriosis in animals that do not menstruate. So we believe there is a clear link between the two.
Wow. So what are the most common symptoms of endometriosis besides heavy bleeding? And what long-term kind of risks should patients be aware of?
So first, the symptoms can vary between different people quite a bit. However, and I think what's very frustrating for patients and physicians, symptoms do not always reflect the severity of the disease. You can have very mild symptoms, but very severe disease. You can have very severe symptoms and mild disease. They don't always correlate. Very frustrating for both patients and their doctors. The most common symptom reported is monthly or cyclic pelvic or abdominal pain, either inside of the period bleeding time or outside of the period bleeding. And then the second one is dysmenorrhea, very severe cramps and issues related to the onset of the period. Also, pain during sexual intercourse is a symptom that many people have. Pain with urination, pain with defecation are not uncommon among those who have endometriosis affecting their bladder or their rectum. Other symptoms include, run-of-the-mill GI issues. Abdominal bloating is really a big one. Many complain about constipation. So symptoms typically worsen with time. Many of the patients reflect back on a time when their symptoms were a little bit less when they were younger, yet they had them. We often remind people it's not normal to miss school, work, or your social events due to painful periods. So if you're staying home because of pain, that is not normal and it should be addressed. In the long term, like I said, 4 out of 10 patients with endo experience infertility, and that can be overcome by in vitro fertilization, for example, and many women are helped. But also women who have endometriosis are at increased risk for very rare forms of ovarian cancer and endometrial cancer, as well as autoimmune diseases like rheumatoid arthritis, lupus, and thyroid disease, as well as stroke and cardiovascular disease. So patients with endo need to be aware of what those future long-term risks might be.
So you've said a lot, Dr. Metz, but just want to go back to the pain, because that's like a hallmark kind of symptom of endometriosis. But one might say, isn't periods, when a woman is having her period, she is expected to experience some pain and cramping. So how do you determine what could be endometriosis versus normal period pain?
It's very challenging. I think when pain increases with time, That's something that people should be very much aware of. And if the pain actually puts you in bed, that is not normal. That is not normal period pain. And I think, you know, having genetics as a principal risk factor, sometimes young people get not good advice from their mothers or their aunts who said, oh, this family is cursed with that pain. You have to take your Tylenol, and that's normal. And that's a challenge.
But sometimes these women don't even know that they have endometriosis, and we'll get into how long it takes to diagnose endometriosis in a little bit. But also some of the other symptoms you mentioned, constipation,
Yep, they're very vague,
etc., could be related to other things.
Absolutely, and I think that's what makes it a challenge for physicians and patients.
So if you could tell every patient one thing about advocating for themselves with these symptoms, what would it be?
I tell them, listen to your body, listen carefully, monitor and track your symptoms, keep track of it, and then share that with your healthcare provider. If they don't listen to you and respond, then you have to find another one.
So what are some of the major challenges patients with endometriosis face when trying to get an accurate diagnosis beyond just the symptoms themselves?
We think getting an early diagnosis is the major challenge, or one of the major challenges for these patients. Endometriosis is most accurately diagnosed using a surgical procedure that we call laparoscopic surgery. They make some incisions in the abdominal cavity, 1/4 to 1/2 inch long. They insert a camera in order to look for the lesions. And when they find suspecting lesions, they remove them. We call that a biopsy. And then those biopsies are reviewed by a pathologist who looks for the cells that should be lining the inside of the uterus. And when they find those cells there outside of the uterus, they label the patient as a diagnosis of endometriosis.
But this could take years to get to that point because
it could take years.
Yeah, because of all the reasons we mentioned before. Women are supposed to have period pain. People don't listen to their bodies, track their symptoms, write them down, have discussions with their physicians about this. Yep. So how long typically does it take to make this diagnosis?
So it could typically take up to 8 to 10 years. In our recent survey, we found that on average it was 9, which is right in the middle of what the published literature
9 years.
Indicates.
But in this 9 years, a lot of damage, could have happened.
Yep. I just spoke to somebody last week who wanted to join the study. They had symptoms since they were 10, and they were diagnosed at 28.
So 18 years.
That's 18 years. In our study, we've had mothers and their adult children be diagnosed in the same year.
So you mentioned study. Let's talk about the study. What exactly is the study?
So our study, Dr. Peter Gregerson and I co-direct what we call the research OutSmarts Endometriosis study. We started it in 2013. And our goal was to study menstrual blood or menstrual effluent to better understand endometriosis, really for 2 goals. The first goal was to develop an earlier diagnostic for endometriosis that would be not as invasive as laparoscopy. I mean, we call laparoscopy the gold standard, but it does have some issues with accuracy, and we think that it's very good about 70% of the time. That means it's missing about 30% of cases.
And that is when they go in with the camera looking for these cells.
Yep. They call it a gold standard, but it has issues. So
What are some of those issues?
It misses. People are unable to see these lesions. Many of them are microscopic. Some of them grow into the tissues and avoid detection. And clearly, when it's microscopic, physicians can't see them. So there are major challenges in looking for those lesions and finding them.
So this is a challenging disease all around.
Yes, absolutely. And, you know, the other main effort for studying endometriosis in our laboratory is to identify new treatment options.
Which we'll get into, but how did you get involved in this work?
So I started working on endometriosis in the late 1990s. I met a collaborator from Quebec who contacted me because he was very interested in the role of inflammation in the formation of the lesions. And he was very interested in the cytokine that I was working on at the time, macrophage inhibitory factor, MIF, and he wanted to collaborate with me to see whether MIF played a role in lesion development. So he was the person who actually got me started working on endometriosis. And then we did several studies together, and I served on a committee for his PhD student, and we had a very nice friendship and a collaboration. And then Dr. Peter Gregerson received a grant award from the Endometriosis Foundation of America to start banking samples for endometriosis. And he knew very little about endometriosis. And so we started collaborating because he learned that I had been working on it. And we came to the final decision that we would study menstrual blood because there were reports in the literature that the inside of the uterus, that uterine lining in women with endometriosis, was different from people who did not have endometriosis. And we thought, well, that's shed every month as menstrual blood. So the answer could be found in that menstrual blood. And we thought, wow, that's kind of obvious. And we looked in the literature, and no one had studied menstrual blood to understand endometriosis. There was one paper published looking at menstrual blood because of infertility issues by Renata van der Molen, and I collaborate with her. And there were several papers on stem cells that were found in menstrual blood. And of course, the endometrium, the inner lining of the uterus, has to regrow every month. So yes, of course it's filled with stem cells. And so many were going to harness those stem cells to treat cardiac ischemia and brain ischemia. Had nothing to do with learning about the uterus, the inside of the uterus, which is so amazing. They were going to use it for another purpose. But our idea was these cells, these tissues that come from the uterus will tell us amazing things about the inside of the uterus and uterine health.
Well, we can't wait to hear what amazing things you have found out, but just want to get back to like treatments. If the gold standard is only accurate approximately 70% of the time, it makes it even more difficult to come up with effective treatments for endometriosis. Are there treatments? How do you treat endometriosis?
So there are two major ways to treat endometriosis. The first one is surgery, and that's used in very severe cases, and minimally invasive gynecologic surgeons go in with that laparoscopic surgery with the camera, and they remove all the lesions they can find. And that is effective in some people. Some people have that surgery multiple times, okay? And it does help relieve pain in many, many people, but it's reserved for very severe cases. The other more common treatment that most people get, and the first line of treatment, are hormones. And that's usually in the form of oral contraceptives or progestin containing drugs. And if they don't do well with those, they move on to stronger drugs like GnRH agonists that put these young patients into menopause. Now, it's important to realize that those drugs that I just mentioned, these hormone-based drugs that are FDA approved, are only FDA approved to treat pain. They are not FDA approved to treat disease progression. They are used to treat pain. And I'm sure you could think of other pain relievers that might work better. We often chuckle that many conditions that affect women are treated with hormones. And clearly there are alterations in hormones in the setting of endometriosis. People tend to have high estrogen levels and poor progesterone sensitivity. However, we believe there may be other ways in addition to hormones that may target this disease in a different way to either prevent progression and really alleviate some symptoms in a better way.
So how does the hormone work? How does the hormone work in the treatment of endometriosis?
So the hormones typically work by reducing the endometrial lining so that their menstruation is altered. And according to the results of the study, hormones delivered to patients reduce their pain. Now, exactly how that might happen, I don't think we completely understand. And some people do really respond well to hormonal treatment and manage quite well. And some patients do not manage well, and then they go on to have worse symptoms, and then go on to GnRH agonists, and then go on to have surgery when that doesn't work. We firmly believe there may be alternative treatments out there that have not been tested. Clearly, this is an area that's very underfunded and an area that really needs attention.
Why do you think it's so underfunded?
You know, I wish I had the answers to that. It's
because it's a big problem. It's a debilitating disease that affects millions of women. You referenced 6 million just here in the United States. So why aren't we paying more attention to this?
So the funding agencies have allotted very small amounts of money to some of the women's health disorders. It has garnered more attention in the last few years. At one point, our country spent more money studying smallpox, which is completely eradicated, compared to endometriosis. And there are other diseases that are as common as endometriosis, such as diabetes, that gets much more funding. And I'm not saying that it's not worth funding those diseases.
Right.
I think it's worth funding all common diseases and diseases that really negatively impact people's lives. I want these young people to achieve great success in their life. And I think when they have challenges getting their education and maintaining jobs because of absences, it's a loss of opportunity. We used to think the brain was the unexplored frontier, but I think in the last 5 or 10 years, the brain, we know a lot more about the brain than we do the uterus. And the uterus is a pretty common organ, and it's a pretty important one, if I may say so myself. We don't have a replacement at the moment. And I think it'll be part of people's annual exams. I think the assessment of menstrual effluent may just be part of the exam.
Hello and welcome back to 20-Minute Health Talk. I'm your host, Sandra Lindsay. Today we'll continue our conversation with Dr. Christine N. Metz about endometriosis. But just want to go back, Dr. Metz, to understand the migration of these cells outside of the uterus.
How does it happen?
How does it happen?
So exactly how endometriosis progresses or becomes a condition is hotly debated in the literature, and we don't know the answer. But I could tell you that the most commonly accepted theory is called Sampson's theory. It is over 100 years old, and Sampson was a surgeon who did abdominal surgery on women and found period blood in their pelvic cavity during surgery if they had their period. And he concluded that this may be the cause of endometriosis and the lesions growing outside of the uterus. So in humans, the uterus is not a closed system. So that each month when people have their period, there is period blood that is pumped through the fallopian tubes and into the abdominal cavity. So we often say, well, why is that causing endometriosis in 10% of the population and 90% of the population does just fine? One hypothesis is that the body is unable to eliminate those cells once they get to the abdominal cavity. Maybe there's something wrong with the immune system. Another hypothesis might be that the organs and the abdominal lining in patients with endometriosis is stickier, and that's why the cells come and they stick there. Our hypothesis is that within the uterus, those cells have been modified in some way so that when they leave the uterus, they're pathologic. They're going to promote disease. They promote lesions, either formation or the lesions that have formed to develop more. So our hypothesis has really been focused on the menstrual blood itself and how there are alterations in patients with endometriosis versus healthy controls.
Which leads me to your groundbreaking research. Could you explain what menstrual effluent is from a scientific perspective and why it holds such promise as a diagnostic specimen for conditions like endometriosis?
So we call it menstrual effluent because in addition to having blood within it, it also has whole pieces of tissue. It has that endometrial lining tissue, the equivalent of a natural biopsy per se, right? And we think that that's a major treasure that is found there, and we've been really studying those tissues. The menstrual effluent also has free cells, it has blood, it has mucus, and it has some things from the vaginal tract. So it's a little bit different than what we would think of blood. And certainly our peripheral blood running through our bodies has no tissues in it. So that's the main difference. And our work has really focused on studying those tissues in incredibly detailed ways. So we look at the gene expression patterns in the cells that are in the tissue, and we look at every gene that they express through a method called single-cell RNA sequencing. And it creates a lot of information for us. And we work with computational biologists to digest all that information and really narrow it down to what gene expression differences are there in patients with endometriosis versus healthy controls, and what cell composition differences are different. So we've identified that patients with endometriosis have fewer uterine natural killer cells than patients without endometriosis. And those cells are really important in fertility, and they help make the uterine environment a very good niche, a nice little place for an embryo to implant. And the other thing that we see at the cell composition level is that they have many more B cells in the menstrual blood or menstrual effluent of patients with endometriosis. And we think that's a sign of chronic inflammation. And so much of our work has really been looking at very detailed differences between specimens, menstrual effluent specimens from patients with endometriosis, symptomatic patients, and healthy controls. And to date, we've identified many differences in patients with endometriosis versus healthy controls. But most important is that, can we identify endometriosis in a symptomatic person who hasn't yet been diagnosed? And those studies are underway. We are enrolling patients who are scheduling their laparoscopic surgery to be diagnosed, and we try to get a menstrual effluent sample before their diagnosis so that we can compare their pre-menstrual effluent sample with their laparoscopic surgery results. Do they have endometriosis or not?
So, a lot of scientific terms. So what does all this mean for the future of women's health?
So we are working on developing and commercializing a diagnostic for endometriosis based on menstrual blood or menstrual effluent. We established the ROSE study in 2013 and have enrolled over 3,700 participants who have received a menstrual collection kit in the mail, and then they ship it back to us by FedEx, and we do the analyses. And we just continue to gather data and are looking to go toward the FDA route for review and approval down the road. We honestly hope that someday menstrual effluent analysis is just as much a part of a GYN annual visit as a pap smear is. That's one big dream. Another big dream is that people have an earlier diagnosis, get earlier treatments, and suffer much less. And if, you know, the icing on the cake is whether we could actually find ways to prevent it in people that are at risk. Those are the big dreams.
So in a perfect world, you know, patient goes to their OBGYN, brings their data, you know, listening to their bodies, documenting their symptoms, discusses it with their physician, and their physician can say, okay, we need a menstrual effluent sample, and be able to see whether or not they have endometriosis much faster.
That's our big goal.
That's your big goal. So how far away would you say you are from that goal?
We would hope to think that we are within, let's say, 2 years of trying to go down the regulatory route, that we'll have enough data to bring to the FDA to say, what do we need to do to prove to you that this is a diagnostic path? It's going to be a challenge. Having a home collection, although participants and patients love it, it is a bigger hurdle for the FDA because the sample is could be manipulated by the patient, and it's not collected directly by a doctor. But we believe that that's what patients want. They would much rather collect it in their own home under their terms. We also think that collecting the menstrual effluent is a challenge. Not everybody can easily collect it. It does require some education, so that has to be made very simple for patients.
How do patients collect the menstrual effluent now?
So right now we have mostly 2 options, although most people use the first. We use a menstrual cup, or they can use a menstrual disc. So the menstrual cup is inserted, and it could be inserted for up to 12 hours. And we've been lucky to have Diva International provide us our cups for free for the study, and they've been very generous over the years. I also want to thank all of Northwell Health for all their generosity Northwell Holdings has been very supportive of the study as well. Many physicians here participate in our study and refer patients, and Northwell has been an amazing place for us to do this work.
And you've also received numerous accolades for this work. Not that that is why you do it, but it's also important to highlight that as well.
Yeah, it's exciting. We just won the RADx, Rapid Acceleration to Diagnostics for Endometriosis grand prize yesterday, so we're very excited. And that money will be used to help us commercialize our discovery into a diagnostic test.
What other challenges do you foresee with getting the FDA approval for this kind of study, for this kind of diagnostic, rather?
The biggest challenge to us, in addition to collecting menstrual effluent from patients before their laparoscopic surgery, which is sometimes hard, not all patients are menstruating. Some people have their surgery before they would menstruate that month, so we're not able to collect, so there are challenges there. But the laparoscopic surgery itself, like I told you, it's called the gold standard, but it itself has some inaccuracy and cases are missed. In our study, we've met many people who have had the diagnostic surgery multiple times before they're diagnosed. And that's the only thing we have to compare our test to. So we're comparing our test to something that is not quite accurate, which I think is a challenge.
So these women have been told before, after going for that laparoscopic procedure, that they don't have endometriosis, yet your study has found that they have endometriosis?
No, we have found in our study that many women have undergone the laparoscopic surgery more than once before they were diagnosed.
Okay.
So we're comparing our results to something that might be problematic. It's not perfect. I also should add that there are other diagnostic procedures that are used now. There are transvaginal ultrasound imaging as well as MRIs. They're never going to be definitive in knowing what those lesions might be. So they may see a cyst on the ovaries. Is it a cyst on the ovaries? Is it an endometrioma, a lesion of the endometriosis? Or is it ovarian cancer? Those challenges are in diagnostic imaging. They're not definitive. They may be able to identify lesions, but you won't know what those lesions are. So we don't compare our results to imaging analyses. Now, there may come a time that imaging gets better. But right now, just like cancer imaging, first they look to see if you have a lesion. They can't tell you whether it's cancer until they biopsy it, right? So the image itself may not be diagnostic, but they are being used more. Our concern is that the imaging approaches are likely to only find larger lesions. That means you're omitting the whole teenage population that we think have so much to gain from an early diagnosis. And we enroll teens in our study, challenging as it may be. And you know, Amber is working very hard on this, helping to, and a special shout out to Amber, who works with all these participants in gathering their samples. It's a challenge.
So can early diagnosis prevent the spread?
If we had treatments that prevented the progression of endometriosis, that would be great. As of today, we have never had a clinical trial in the United States that I'm aware of, or anywhere in the world, that examined whether a drug for the treatment of endometriosis stop the spread of lesions, because it would require multiple laparoscopic surgeries, pre and post, and show that the lesions either disappeared or stayed the same. we don't know the outcomes for some of these things. And perhaps imaging will help with that. And perhaps analyzing menstrual blood will help understand people's responses to therapies.
For such a debilitating disease, there's so many unknowns. But one thing we know is that you continue to do your groundbreaking research. So how can our listeners actively participate or help in this, in advancing endometriosis research?
So anybody can, in North America, can participate in the ROSE studies. We have multiples that are listed online, and if they just Google endometriosis and ROSE or Northwell ROSE, they will find our webpage immediately. It'll come right up. And on that page are inclusion and exclusion criteria for the various ongoing studies. I will say that we are always looking for healthy controls, as well as symptomatic patients who have not yet been diagnosed, and whether they're thinking about being diagnosed or not is fine, as well as people who have been diagnosed with endometriosis. So we enroll all of those participants for studies on endometriosis. We're also interested in studying menstrual blood for other uterine health disorders, which we think it'll be very useful for. Well, infertility is a very obvious one. So unexplained female infertility could be rooted in a problem in the endometrium or the lining of the uterus. There's a condition where you can have an infection in your uterus. It's called chronic endometritis. People used to think that the uterus was sterile. We now know it is not sterile. And many of us have infections that go undetected because, again, this is something that is not diagnosed in this country. The symptoms could be anything from nothing to very vague that you wouldn't prompt you to see a physician for analysis over. But it is detected and diagnosed in the setting of infertility. So patients who don't succeed in their in vitro fertilization steps get tested for chronic endometritis using a biopsy, an endometrial biopsy. There are other things like even early stage endometrial cancer, uterine fibroids, another thing that really affect women in some very severe ways that could be detected possibly through the analysis of menstrual blood. We think of it as a window right into the uterus. What's going on there?
So are you currently exploring any of those conditions?
Yes, we have studies that we're collaborating with Randy Goldman up in infertility. And we've been enrolling patients with unexplained infertility. And we've been comparing the endometrial biopsy results to menstrual effluent results and trying to learn more about chronic endometritis to develop better diagnostics for it, basically. It seems very sad to think that a patient would go through 2 rounds of IVF to find out that they needed antibiotics. I think it's a pretty painful experience that they could have been treated with antibiotics. And we also are very interested in PCOS, polycystic ovary syndrome. We track that in our participants. Similar observations have been reported that the uterine lining in those patients is different. And we track that information in all of our studies. And we've been looking for clues as to how we might be able to detect PCOS.
So a lot of promise being held in menstrual effluent, right?
One person's trash is another person's treasure.
And we thank you so much for, for doing your research in this area. I can't wait to see, what comes of it in the next 2 years or earlier. What else in terms of, a diagnostic pathway, getting FDA approval, etc. But looking ahead, Dr. Metz, what might the future of assessing and managing uterine health look like for patients in the next 5 to 10 years, especially with this novel diagnostic tool?
I actually think that we may even find novel conditions affecting the uterus that have never been described before. I just think that the uterus is really an unexplored frontier. We used to think the brain was the unexplored frontier, but I think in the last 5 or 10 years, the brain, we know a lot more about the brain than we do the uterus. Mm-hmm. And the uterus is a pretty common organ, and it's a pretty important one,
yes,
if I may say so myself. We don't have a replacement at the moment. And I think it'll be part of people's annual exams. I think the assessment of menstrual effluent may just be part of the exam, looking for signs of various conditions that affect the uterus. And there are conditions in the body that could affect the uterus in ways that we don't really understand now because we're not really studying it.
Dr. Metz, I could go on and on talking to you about this, and I will invite you back later on. I hope to invite you back in 2 years
that would be
to
great.
Discuss, your FDA approval.
Sure.
Thank you so much for your passion. Thank you for the work that you're doing, you and the team at Feinstein Institutes. To our listeners, thank you as always for tuning in to 20-Minute Health Talk. Until next time, be well.